Imagine we're in Saskatchewan and we have this disease. Imagine the disease infection rates, they rise more than about 1,200%, and they do that in less than a decade. Now, let's say this is a disease that happens to infect hundreds of newborns, a disease that sometimes kills them. Now, take this whole infection you're picturing and know that it's not imaginary. This is something real, and the disease we're talking about is syphilis. Fun, right? Classic disease is back, and infectious disease specialists here in Saskatchewan are trying a new tack in trying to stop it. Once again, Stuart Skinner says this all hinges on bringing medicine and care to the people, not making them wait. Stu Skinner is our guest today on Researchers Under the Scope. Hi, I'm your host, Jen Cannell, and we are recording this on June 17th, 2025. And yeah, you heard right. We are talking syphilis, the disease that's spread through sexual contact, the one pregnant mothers can unknowingly pass to their infants. And this is one that Stu Skinner's watching. He's spent about 15 years as a physician. He's worked with Indigenous communities right across southern Saskatchewan. He's the founder, the director of the Wellness Wheel Medical Clinic, and yes, Stu Skinner, also the name of the goalie, starting tonight for the Edmonton Oilers in Game 6 at the Stanley Cup Final. That's a different Stu Skinner. They got lucky. They share a name, and the one that we get to talk to today is way more focused on shutting down and shutting out infectious diseases. Stu Skinner is a researcher and assistant professor at the University of Saskatchewan's College of Medicine, and he joins us now. Hey, Stu.
Hi, Jen. Thanks for having me. It's great to be here. The only thing that makes me more happy than stopping pox is stopping infections. So it's wonderful to talk to you.
Right. Did you ever actually play goalie?
I did for a couple of games when I played hockey, but I was forward. Yeah, I did. You have to have a certain mentality to be a goalie.
This is what I hear. We'll leave that Stu Skinner to it. But in terms of the stuff you're trying to stop STIs, sexually transmitted infections. You want to stop HIV. That was always a big one for you. The last time we talked to you, we were talking about diabetes, actually, and how chronic it tends to be in a lot of Indigenous and remote communities. But we're also talking syphilis, which is isn't that one of the classics when it comes to STIs? What kind of a disease even is this?
Yeah, it's been around for hundreds of years. I think, going back to the history of Christopher Columbus, even syphilis comes up with him. Al Capone died of syphilis as well. I don't think it's surprising that in a situation where we have lots of HIV or other sexually transmitted infections, that we would see something like syphilis also become quite predominant. And that's because these infections often travel together and often they are transmitted the same way. And they like to gang up together. And in the infectious disease world, we call them syndemics, which means that the two infections not only travel together, but they can make each other worse. So seeing a lot of these other infections related to sexual behaviors or poverty or issues around mental health or houselessness, we will see these other types of infections pop up as well.
When would you say that the spike in cases kind of hit your radar, though?
Well, they really started to increase 2019, 2020. At that time, we were really focused on COVID for 2020, 2021, and there was an issue around access to testing, and testing significantly dropped. And then coming out of COVID, as access to healthcare and that opened up, more people got tested, more people were getting sick. That we really saw a big increase in cases. And Alberta had been ahead of us, especially northern Alberta, in terms of seeing this syphilis epidemic in the late 2010s. And then it kind of just traveled over across Saskatchewan in the last few years. And then definitely in the last 3 years, the patients that we've been seeing who we see syphilis everywhere now. So what I mean by that is not only being tested or positive, but presenting with other symptoms such as vision loss or meningitis or rashes, or in hospital with fevers, in addition to the sores or genital type of symptoms of infections. So it's all across healthcare.
It's infecting really small patients too, right?
And congenital syphilis is absolutely a major concern and tragedy. Pregnant moms who, again, either may not have access to prenatal care or at prenatal testing get diagnosed. That can be transmitted to the fetus, and we call that congenital syphilis. So babies associated with infant mortality, stillbirths, congenital malformations. And there's been a lot of cases seen in pregnancy and in pediatrics and newborns as well.
If you can catch syphilis early, and how early do you have to catch it? What do you have to do to get rid of it or to make it not contagious?
Is treatment with intramuscular penicillin. We call that Bicillin. There's also some oral antibiotics such as doxycycline that are available to treat it. And so the general treatment is an intramuscular injection. So it's a long-acting penicillin that goes into the gluteal or butt cheek area. And it's given, if you just recently got it, call that primary syphilis, or in the last year, you just get the one dose and that treats and gets rid of it. Sometimes if you've had it longer, then there would be 3 doses, intramuscular injections, a week apart. There's a couple challenges that come up with that. One is that it is reliant on someone coming in with a sore or with symptoms of syphilis or wanting to be tested or having kind of risk-based testing.
They actually have to walk in themselves.
Right.
Right.
Yeah, coming into healthcare, if they do get diagnosed, public health will test and do contact tracing, which is easy if it's contact names are known or they have addresses or phone numbers, but becomes much more difficult if they don't have a phone or a fixed address, or if people are uncomfortable disclosing contact information. The other challenge with people presenting with early symptoms of syphilis is one, the sore, like a red ulcer or raised lesion at the site of contact, which could be in the genital area, the anal area, or in the mouth, if it's oral sex, will be there for a couple of weeks and tends to resolve on its own, but the person's still infectious and they still have syphilis. And the other challenge, especially for women, is it's painless, so it doesn't hurt. So if you don't see it, you won't know it.
You won't be seeking care for it because nothing's wrong.
That's correct.
Ugh. Okay, so this national call goes out for, okay, what can we do to eradicate syphilis? And your team at Wellness Wheel, you went ahead and you assembled more people and you said, yeah, let's do something about this. So what'd you do?
Yeah, so if we went back a few years, we had the first part of the study, which is called the Shiver Study, and that was in partnership with Indigenous Services Canada, Unity Health Network in Toronto with Dr. Sean Bork and their REACH team. We had some support from the Saskatchewan Health Authority, where that was the first part of the project, Shiver, that ran from mid-2023 to late 2024. And then the second phase, which is more or less a continuation of it, and Ayong Wami Ziwin initiative, which is the CIHR funded, and the lead investigator is Dr. Sean Rourke, again he's out of Toronto, but it has been tremendous support. And that is actually more of a prairies initiative in partnership with Northern Alberta as well as Manitoba and some of the Northern Territories as well. The syphilis epidemic that we're seeing is mostly in the prairies.
That northern Alberta through northwest Saskatchewan and then spreading. Okay.
That's right. Yeah.
I was looking up the word Ayangwamiziwin, and I understand it's an Ojibwe or Anishinaabe word for like kind of being careful, like being prepared. And I was thinking about that. What does your project entail?
I mean, I guess the other partnership in that is with our Wellness with Clinic, which is the clinic that I work in, a nonprofit clinic, which is based on outreach care. And we've really worked towards going to where patients are, where people are, especially with the focus on First Nation communities, those people with the least access to healthcare or the health system. And so rather than get a lab requisition, which means going to a doctor's office or even through public health, then you get a lab requisition and you got to go to a lab. And lots of times you might have to make appointments to go to the lab and then get to the lab to get the test done, which then means going back to the clinic or going back for follow-up of the test results to get those test results. And then depending on where you go, then you might have to make an appointment to get treatment, all of which are, every step is an opportunity to get lost or disengaged from care.
Right, to walk away.
Yeah, so what we do is we go to where people are and we test them. And that was a lot of initially with HIV clinical care and then testing, but doing a point of care, which means a finger poke and getting a result right away. Patient gets the results. If we would just verify if they've had syphilis, try and verify if they've had treatment before. If not, then they are treated or offered treatment right at that point in time. So you take potentially a number of visits over a long period of time, lots of opportunity for lost follow-up, and condensing that to an hour.
With the finger poke, you get a result for both HIV and syphilis or for syphilis?
For both. So again, what we want to do, and I think as a general rule, and I kind of mentioned the word syndemic, where the infections kind of gang up, yet in so many ways we live in a disease-based model in healthcare, meaning you see one doctor for A and another doctor for B, another doctor for C. Even in infectious disease, you might see me for HIV, but then you're going to see a different doctor for tuberculosis, and then maybe you'll see another doctor for hepatitis C.
Never mind the syphilis.
And never mind the syphilis. Or you might have to go to public health because a lot of places don't have the Bicillin for treatment. So even in this initiative, if we just said, oh, we're focused on syphilis, well, we're not, because syphilis has also been driving our HIV rates up. But even if it wasn't, what we want to do is, okay, well, they're sexually transmitted infections. And so let's look at all of those infections that travel together and try to take that concept of a syndemic, but in terms of healthcare.
Treat them both at once.
Right. So people in this study could have got, but they were offered an HIV point of care, they were offered a syphilis point of care, or they were offered both. The vast majority of people were willing to take both. And the other part in the study was to validate a test for the syphilis point of care that it would be good enough to be able to respond to it and treat based on the results. We also did confirmatory testing, so we did get the phlebotomy with it. But as time goes on and as we get more and more better technology and the issue around lab testing and lab services, especially for those who have the least access, becomes more and more required. And probably this is a concept that could be expanded even beyond infections. So diabetes, for example, they want to care hemoglobin A1C, or there's the ability to take, radiologists, for example, are taking ultrasound, or the cancer centers and organizations are taking cancer screening buses out. With all of that same idea.
But wrapped into one point of care.
Right. And what we want to do is then add the treatment aspect into it and also add the continuity into it. So rather than screening and going around and then who's going to follow the patients. And that's where the community piece is really critical, is you're linking in with different either communities, community health providers out there, or community organizations who are connected with the patients, who then can assist and help engage those patients, which might be the only point of contact into any sort of system. that we utilize that as part of our whole health team. So every site and every area and every provider and every community organization and every patient who was involved, we're all part of this team. This is our success.
Can you take me back in time? Like, what would it look like? You'd roll up to like a music festival or a concert or like a powwow, and then what would happen?
So it would depend on what that event was. This is often Nikki Williamson, who's the nurse, and they might just set out at the van and powwow and offer testing with signs that people could come and get tested, usually in conjunction with other health situations or like health booths or community events. And so, for example, there are places, the Losh or other First Nation communities where there would be a specific testing event to it. Others might be a community health days where they're promoting just health in general, and that could be offered alongside. Sometimes it was in powwows. Sometimes it would be, for example, at Queen City Wellness Pharmacy here in Regina, there would be set days for people who are already coming in to connect with that pharmacy for various reasons that they could be offered the study. It all really depended, and the whole concept was to be flexible and mobile and adaptable to whatever that situation was where they needed testing, so that we weren't the barrier. It's our responsibility to adapt to the needs of the community or the patient, rather than vice versa to say, well, we need A, B, C, D, E, F.
Knowing that they're never going to be able to get past C or D.
Right.
And you're just going to have sicker people.
And there's some, it's not easy. It wasn't easy for the nurses to set up and read the results or draw the blood, in a less comfortable environment, but they did an amazing job.
If you want to be effective, go where the people are. The more you think about it, of course, that makes sense. It's just hard sometimes to break out of the clinical model that we've set up across this country.
Right. But I mean, if you think, I don't know, Jen, if you think of yourself, or I think of myself, right? Like, okay, I got to make this appointment at this lab and I got to go there for 3, but, I'm running late at work and there's always lots of reasons. But if you come to my house, you're like, look, I'll come, you tell me what time, we'll make it work and a bit flexible. You're like, okay, yeah. And that's the same thing. And, in this case, we're looking at, a lot of people who struggle with houselessness or mental health or addiction or poverty, but you could be a single mom with 3. And good luck, corralling 3 kids to go is a lot of work. Or you could be a senior who's 88. And there's a lot of good senior programs that have labs that are able to go out. But if you can't afford the lab or you don't have access to the resources that we take for granted, like a car.
Yeah. It makes a difference to show up where people are.
Correct.
Was there any incentive offered to participants? Like if you line up because sometimes people are a little reluctant to line up in public and be like, I'm going to go get tested for syphilis.
Yeah. You're like, what are you waiting for? A syphilis test? Oh.
Right? Like that's.
Yeah. It's, it's generally very discreet, obviously. There's a $20 incentive.
Oh, and then
cash for
everybody gets that.
And it meets the needs of what people are looking for to get them tested, to get them treated. And, we've seen that in a lot of places that, it could be $5 or it could be a good food box. It could be just food.
It could be a lunch bag. Like, here, come have a sub. Like,
but. Right. And people will do that. You'll line up forever. And think about it. I mean, I remember, as a medical resident and, you get a lecture, but you're really busy and they'd have lectures at noon. But you're like, wait, there's food. So I'm going to go.
Yeah. It's a lunch now. I'm going to grab some of that pizza and sit and listen to this.
Right. So this isn't, it's not a unique concept.
It's not without precedent.
Right. And it's just human behavior when you're really busy and you're trying to prioritize what is of value to you, because you're like, I feel well. Why do I want to get this test done? Why would I want some? I'm afraid. What if I am HIV positive? What if I have syphilis? That's just not a priority when maybe you're trying to find a place to sleep for the night, or all these other things that are there. So I think it's something that we've seen that really helps. And I think if we're really looking to make a difference and engage, there has to be some reason for people other than, well, don't you want to be well? Because they
Yeah,
have so
sure,
many
everyone does, but I got other priorities.
right. You're like, well, then I need a house to be well. So continue.
Yeah,
But
get him on a couch.
yeah,
Well, and if you look at the number of people who all walked up, the number of like finger pokes you did, the number of people that you were able to reach out to, what did this show?
oh, it's incredible. This has been, I mean, I guess I'm getting old, but after 18 years, to see how many sites, so I think there's 35 and we're over 50 now, and just keep getting requests from everywhere. So there's this huge web now that can be built upon for other chronic diseases. So 1,797 people who are, the most at risk, with such a large portion never been tested before. The uptake was phenomenal, and it's built on relationships, and which is what I think everything is always built on, is relationships. Oh, I know this person, and I know, this health provider, and everybody respects one another. And so that is really critical. I think recognizing that in this case, this is a need that everybody in terms of the health providers is seeing and acknowledging that because there's so much syphilis and HIV.
When you say so much, what are the rates?
About 16% positivity rate for syphilis and 3% positivity rate for HIV. If your prevalence, meaning the number of people you test for HIV, is above 0.1%, above 1 in 1,000, it is cost effective to test people.
Well, you're getting those numbers then.
Yeah, so we're well above that. And some of those weren't all new infections either, but a number were new HIV and lots of new syphilis diagnoses.
Wow. And also treatments though, and also people who are in contact with people they trust. And if ever they see you again, they would recommend you or come back.
Right. I think the uptake was really, really great. So people willing to do the treatment, even it's not it's an injection.
It's a shot in the butt. Like that's,
and it hurts. It's not a comfortable shot. But we had almost 100 people who were treated who otherwise wouldn't have been. So then you can, it's a way to stop the spread and stem the illness that, our current standard ways of doing things. And to say the health authorities' credit and public health's credit, I mean, they do get out. They have buses and vans that go around, and with the First Nations, the nurses are incredible going out and finding people, getting them tested. But there's limitations. Everybody's also really, really busy. We have not just, our healthcare crisis is also a human resource crisis. In Saskatchewan, especially rural, dispersed population, we're short health providers. And even if in the context of outside of just treating people, so for every syphilis case, and I referenced it a little bit earlier around contact tracing, public health calling them, the amount of time that those nurses have to spend finding contacts, testing them, treating them, follow up is tremendous. So
are we talking like 16 hours a person, 24 to 20?
I don't know. Hours, I couldn't say.
Like entire work days.
Can be, yeah. It's a lot of work. I don't want to speak for them because I don't know exactly, but I know it's a lot.
When other places ask, okay, how do we replicate what you're doing? What do you tell them?
So replicate in the sense of, the biggest question we get is, how did you test so many people? How did you connect with community?
1,797 people.
Correct, yeah. And that was just the first part of the study, the shipper study.
And like, how'd you do it? How'd you get all these people tested?
Yeah, so I always don't know how to answer that question. It's kindness, respect, humanity. Everything is relationships. and respect, and especially in Indigenous communities, Indigenous populations, is that they practice a lot of this, what I've talked about already. And so this isn't going to First Nations just to help them. We actually, I've learned so much from the cultural values that are built into that and the community-based approach that is built into what happens in First Nations, and trying to we have a lot to learn back from them that would really be beneficial.
Act like a human, have real relationships, but the people are already out there connecting through a lot of Indigenous-led organizations. If you let them lead where you need to go, if you listen, you pay attention, and you let them be in charge, you can get to a lot more people. You can get those thousands of people tested.
That's right. It's well stated.
Okay, well, onward. Good luck with it. What do you do next?
Hopefully win game 6 tonight to pitch a shutout.
Hopefully. Okay, fingers crossed.
What's next?
Yeah, like you had funding renewed for another year. You're going to expand this to sites in the north. Is there predictable long-term funding for this kind of work yet?
That's the next step, is to engage with senior leadership and look at, prove the value of what we do or what this does, and make it sustainable so you can keep really good people, so you can keep those relationships intact to build off of, as I mentioned, into other chronic diseases or other illnesses. So it's always about sustainable funding and sustainable positions. And I think it will be, I have to say that, I've mentioned Nikki before, who is just been incredible at what she did, but there's so many other people. There's Lindsay Iron and Middle Lake Tribal Council, or Cisco, Green City Pharmacy, or Reed up in around Prince Albert, the Takakoo, who just do so much with so little. And this was really like in the context of what the health system is funded. This is like a nursing position with some physician support and some travel funding and incentives and additional data funding, that it's not a lot of investment in terms of what is returned and gained. And that it really is the key, because there's just, it's too hard to maintain. You want us doing the work, seeing the patients, not having to write grants or not
having to prove that you need to exist.
Right, ethics, or prove that, test. That's right. That's what I think we need, that's where the sustainable piece comes.
All right, sounds like you need a health economist to come look at your stats, write it up, do an analysis, and say, this is your cost benefit. Like,
if you got any, if anyone's listening, please, because we're generally just running in on the ground doing the work, and again, it's always strength based, so we're good at that. But then people think, well, you need to get the sustainable funding, and how do you write that in the language that translates into funders?
Okay, could use some help with this, but it matters. Stu, thank you very much.
Yeah.
Like, I hope that you can make that happen. I hope this does
Thanks.
Expand what it can do and really make that point of care testing just a cohesive part of the system that just always exists.
Yeah, I would say it too. We'll keep trying.
Thanks, Stu.
Thanks, Jen. I really appreciate being back.
Stuart Skinner is an infectious disease physician who has spent the last 15 years working with Indigenous people and communities across southern Saskatchewan. He's the founder and director of the Wellness Wheel Medical Clinic. Now, Stu and that crew won last year's PESTA Award, the Publicly Engaged Scholarship Team Award. You might remember him from episode 38, telling us about treating diabetes with black bag medicine. Stuart Skinner is big on bringing care to the people who need it, not worrying about them missing appointments in hospitals or trying to get to clinics that are often hundreds of kilometers from home. If only the Oilers could have the success that real-life Dr. Stuart Skinner does. Researchers Under the Scope is a presentation of the Office of the Vice Dean of Research at the University of Saskatchewan's College of Medicine. We record and produce this podcast on both Treaty 4 and Treaty 6 territories, and we pay our respects to the First Nations and the Métis ancestors of these places. We reaffirm our relationship with one another and thank you for listening to our show, for being a part of it. You can always get in touch with us, ovdr@usask.ca. I'm your host, Jen Cannell. Leave us a review, share the episode with someone you like, and most of all, thank you for listening to Researchers Under the Scope.
Oh, yeah. You know, it's funny. He's got like 3 biographies out. So I bought a bunch of them. And like one of them is Ice in His Veins, a biography of Stuart Skinner. And so then I'll sign them and get them to people. You know, keep your stick on the ice and your eyes to the stars. You know,